والنهارده دكتور ماهر عرض عليها هذا الموضوع وانا قابلته لانه موضوع سخيف شويه مش متعودين عليه في المحاضرات، ودايما ما يكون في نقطه مش متعمقين فيها لما بنفتحها احسن تدي فرصه ان نطلع عليها، وبالتالي I accepted ان انا talk about this subject which is post-transplant lymphproliferative disorders. In البداية some slides about malignancy as a whole. We know that the frequency of malignancy is increased in the post-transplant population with risk from 2.5 to 3 times more than the age and matched non-transplant population, and as well as dialysis population. Also, we have to know that there is a huge variation between tumor types occurring. For example, we have tumors which is very high prevalent in transplant patient when compared to general population, such as non-melanoma skin cancer, which go up to 100 more, and even the squamous cell carcinoma is up to 200 times more than normal population. In kidney and urethral cancer, it is nearly 10 times more than normal. But in case of cancer breast in female, there is no extra risk, and transplants are similar to the general population. Also, which is very sad, that when we are confronted with a patient who is dying from cancer while he has a good function graft, this occurs in nearly 10% of our patients. This not show the expected malignancy to occur, and that occurred or reported in malignancy in, after transplantation. You see here it is much higher than it is expected, the observed one. Then we come to how it occurs. Immunosuppression is the most important risk factor for post-transplant cancer, but also we know that smoking, for example, some viral infections such as Epstein-Barr virus and CMV virus can predispose to cancer, and also the general factors such as elderly patients are more prone to have cancer after transplantation. And there are rare reports of malignancy being transmitted from donor to recipient. Now we come to the mechanism by which cancer occurs after transplantation. Of course, increased risk is more a function of overall immunosuppression, net immunosuppression burden, than a particular type of immunosuppression. So the net immunosuppression is very important. Most immunosuppressants impair the cell cycle and cell growth, and this can lead to cancer at the time. But azacitidine have a mechanism which is unique. It interrupts the repair of ultraviolet light associated DNA damage. So it will respond to malignancy. This will be augmented or amplified if we have a viral infection as well in this as a treated patient, as it will inhibit the p53 tumor suppressor gene. So these are some of the mechanisms by which cancer can occur, but also we know in patients treated by CNI, it had an effect on TGF-beta and vascular endothelial factor. So it can increase angiogenesis, and so it can help in the spread of cancer. In opposite side, or in contrary, sirolimus do the same. It is anti-angiogenic, so it can act as anti-cancer. Actually, we use it, and we used it many times in our patients with Kaposi sarcoma. Cancer such as herpes virus 8 is known to be associated with Kaposi sarcoma, and this may explain the outbreaks of Kaposi sarcoma seen in our patients. And our issue today, which is the post-transplant lymphproliferative disorder, it has a strong correlation with the Epstein-Barr virus. Now we come to our issue today, post-transplant lymphproliferative disorder. We know that it is the second most common post-transplant malignancy after non-melanoma skin cancer. This entity contained a range of disorders, starting from Epstein-Barr virus-associated infectious mononucleosis, a simple issue, which usually occur early after transplantation, especially in young age, to a more severe form, non-Epstein-Barr virus, often non-T cell related malignant lymphoma, occurring usually late after transplantation. So we have a wide spectrum of lymphproliferative disorder, and this table shows this from we know early lesion occurring especially in Epstein-Barr virus positive cases, such as polymorphic type. These two types of lesions occur early, usually young, but also we have the monomorphic type, such as B-cell and T-cell related malignancies, and at last we have the Hodgkin lymphoma related. This figure shows different types of transplantation. On the head up, we have the heart and lung cancer having the highest incidence of malignancy, of course due to the intense immune suppression we usually use, but at the bottom we have our cases of kidney transplantation, so we are somewhat lucky, more than other types of organ transplantation. This shows the progressive increase in incidence of PTLD. In our patient, it is increasing by time after transplantation. But there is something interesting, which is, we see here, the peak is high early in the first year after transplantation. We have a peak of occurrence, and we have a late peak, and in between there is incidence. This is clear in this slide. You see here, this is a French study which has been published in 2011. It shows the bimodal incidence of PTLD. We have peak occurring early, and this usually occurred in young, associated with Epstein-Barr virus positive cases, usually affects the graft. But we have the other peak occurring late, usually occurring adult, with not related, misrelated to Epstein-Barr virus, and usually extranodal. So we have early and late cases of PTLD. Now we stress on the Epstein-Barr virus and its relation to our disease. We know Epstein virus is an overwhelming risk factor for this disease. And we know since nearly 40 years we know information about the relationship between Epstein-Barr virus and Burkitt lymphoma and nasopharyngeal carcinoma. We know this very well, but now we are talking about this PTLD disorders. We know that most of our patients we are dealing with as transplant candidate, 95% of them are Epstein-Barr virus positive. The possibility of reactivation is high if immune suppression is expensive. So we have to tailor our immune suppression not to be overzealous. Children is a unique population. We know that nearly 50% of our children are Epstein-Barr virus negative, which is serious, since they will develop infection from the donor or blood transfusion or from the environment. And recent infection can make them more prone to develop post-transplant lymphproliferative disease, so children is a special entity. Epstein virus-associated malignancies affect approximately 1% of renal transplant patients. The greatest incidence being in the first period, first year, it is up to 0.2% per year in the first year, with a reduced incidence later on, 0.04%. So Epstein-related cases in the first year, but late it is not related to Epstein-Barr virus. The widespread lymphproliferative response to Epstein-Barr virus infection has histologic features ranging from polymorphic T-cell hyperplasia to monomorphic lymphoma. In some of these cases, the lymphoproliferation results in a tumor mass in which the lymphoid cells are usually polyclonal. In approximately 1/3 of patients, the lesions are monoclonal, which is actual malignant lymphoma, although the most common malignant lymphomas that occur in transplant recipients are large cell lymphoma. The whole range of malignant lymphomas has been recorded, including lymphoblastic lymphomas, Hodgkin disease, and a variety of bone-defined malignancies. And this shows the effect of Epstein-Barr virus. In the first year, we have high incidence of Epstein-Barr virus-related lymphomas. And we come to the relationship between immune suppression and Epstein-Barr virus. It is thought that immune suppression will disrupt the CD8 positive cytotoxic T cell, which makes surveillance for Epstein-Barr infected cells. So allowing latently infected cells to undergo replication, causing this lymphoid disorder. Recipient and donor Epstein-Barr serologic status should be known pre-transplantation. Since if you have negative patient, he is high risk to develop Epstein-Barr infection. Consequently, he will be high risk to have this lymphproliferative disorder. Epstein-Barr virus infection post-transplantation is manifest usually as fever, malaise, pharyngitis, lymphadenopathy, hepatosplenomegaly, lymphocytosis, and also the patient can present by a form of hepatitis, pneumonitis, and even pulmonary suppression. What are the risk factors? Of course, Epstein-Barr virus serology negative, depleting antibodies, and high level of immune suppression, net immune suppression. The development of primary Epstein-Barr virus infection, especially such as in children who are negative. Single B infection, co-infection is a predisposing factor. And for the late cases, the risk include old age, the length of immune suppression, and of course, the net or cumulative dose of immune suppression. This table from a French study, which has been published in 2012, and shows these significant risk factors, including the age, period after transplantation, combined kidney and pancreas transplantation, Epstein-Barr matching, HLA matching, and induction therapy. All these are risk factors to develop the disease. Immune suppression, we know most commonly when intense immune suppression is used to treat resistant infection, so always we have to be cautious giving aggressive immune suppression unless it is strong indication. Post-transplant liver disease regresses completely in some patients when immune suppressive therapy is reduced, with or without concurrent antiviral infection, and on the contrary, also case will regress and could be fatal. It is now generally believed that post-transplant proliferative lymphoproliferative disease and malignant lymphoma are inevitable consequence of effective immune suppressive therapy, regardless of the particular immunosuppressive agent used. So we are paying for better graft survival, but we have malignancy. And this shows different type of immune suppressive protocol and its relation to occurrence of lymphoma. You see the stronger the immune suppression, the more the lymphoma-like and like disease. Here, this is a good study which compared the high dose and low dose cyclosporin, its relation to cancer. You see, high dose cyclosporin have more incidence of cancer to develop. And this is the MMF, when they examine, look for the line lymphoma, when they compared MMF and non-MMF containing protocol. Either there is no difference, or even with MMF, the lymphoma is less. So it seems MMF is neutral, or it could be somewhat better for cancer. This is another slide showing the same information, and here this is the EMEDOR. It's an experimental study in rat, immunocompromised rat, containing human cancer cell, as they follow the progression of cancer under different protocol, alternated mice taking the step up, so progression of the tumor is more, And when you give sirolimus inhibitor or inhibitor, the progression or multiplication of cancer cell is significantly less. So it seems it has anti-cancer. This is why when they examine this lymph node in a child with lymphoma, they can recommend presence of BS6, which is one of the methods by which the inhibitor function. So inhibitor is presented in lymphoma cell. So when you give anti-inhibitor or inhibitor, this could be the mechanism by which cancer is developed, is knocked out. The same study showing the sirolimus and cyclosporin treated, of course, there is a great difference between cancer to occur. It is more with calcineurin, less with sirolimus. Now we come to another, the more recent immunosuppressive drug, belatacept. We know it is very potent if you compare it to Stella. It is more potent, fourfold higher ability for CD86, 10 times more effective, more potent. So what? Okay, regarding malignancy. This is a study, you know, the benefit study in which they used the living and the standard criteria deceased donor, and benefit extended in which they used extended donor criteria. There are three groups of study. The first one, they used maximum intense, I mean more dose of belatacept, and compared it to low intense, lower cumulative dose of belatacept, and compared to cyclosporin treated patient. You see how post-transplant lymphocytic disease, it is very clear. If you look to overall malignancy, the more intense, when you compare to low intense, there is a significant difference. And most of them, when you compare to cyclosporin treated, if you go to lymphoma, it is, of course, more intense, the higher dose, more than the lower dose belatacept, and most of them are more than cyclosporin. And what is very difficult, if you look to CNS involvement, it is more with belatacept than with cyclosporin. So you get better graft survival, but you develop malignancy. Again, this shows the same renal affection, CNS affection, fatal outcome with belatacept, higher dose, more than lower dose. Both are more than cyclosporin. And here, when they look for Epstein-Barr virus negative and positive cases, you see there is significant difference. Now, so we can say that with the new immunosuppressive drug, we have earlier post-transplant lymphocytic disease, more frequent CNS location, high lethality, strongly associated with Epstein-Barr virus donor-recipient mismatch. And of course, if there is CMV, it will make the story more bad. This is the clinical presentation. It could be asymptomatic or with some general symptoms such as weight loss, fever, night sweat, sore throat, malaise, anorexia, and these things. It may include lymphadenopathy, hepatosplenomegaly, tonsillar enlargement, focal neurological lesion if the brain is involved. Disease may be nodal, extranodal, localized, or disseminated. So we have different varieties with different organ involvement. And this shows how, with time, how different organ affected, brain, gastrointestinal, kidney. It is increasing, especially the gastrointestinal lymphomas. Investigation, we have to look for anemia, urate, MPH. We have to look at high risk subject. We have to look for PCR for Epstein-Barr virus. We have to do CT. We have to do CT PET examination. We have to do histologic examination for tissues. Of course, lumbar puncture if we think brain is involved. Prevention, of course, over-immunosuppression. We have to avoid over-immunosuppression. We have to look for Epstein-Barr virus infection. We have to look for the negative And also in some high-risk cases, we may give Epstein-Barr virus specific cytotoxic lymphocyte HLA matching. It can manage high-risk patient. If we come to the management, it is multidisciplinary. We, a nephrologist with the oncologist, we have to go together to manage this case. And these are the treatment, reduction of
Dear doctor, your time is up.
I have. 2-minute like Dr. Matt. Okay. So, reduce immunosuppression. Rituximab could be of help if the tumor is big. Chemotherapeutic agent, adoptive immunotherapy, but of course you are attacking the cancer, but possibly you will lose your track. These are some treatment plan. Of course, it is adopted between oncologists. It shows some results. You see some success here, 52, 62%. And these are the complex protocol they use, but usually, as nephrologists, we say to all oncologists, send it.